Good evening, everyone. How are you all? Great. So, as you are already aware that there has been a bit of change with the class timing, as I have also explained to you. So, from from now onwards, my classes will be at this time, so 7:30 p.m. Sydney time. I tried to make 7:30 for all the classes, but our all other mentors they prefer to take the class at 8:30. So I'm keeping it at as a 8:30 p.m. for the question solve classes. But for me, I prefer more to finish a bit earlier than later at night. Okay, and it's also better for a lot of you, I hope. So now tonight we are going to do our second class on pediatrics. Do you guys have any questions on our first class that we have taken? Okay, so let's move on to our second class on pediatrics. Pediatrics, there is a lot to discuss, so we will need to be a little bit quick so that we can finish everything in these three classes. Okay, so we are going to go with the infection in children, and the childhood infection is normally we go through JM for it. JM has everything that you need, so you can open up the chapter 86 from JM 8th edition. And Dr. Ahmad, omphalocele is not a cause of respiratory distress. It was just a case of like a neonatal issues or congenital abnormalities, but it's not under respiratory distress. Pediatrics ENT, we will do in ENT. Yeah, mostly. So a lot of things we will discuss in pediatrics, few things will be discussed in ENT class. Okay, so let's open up your chapter 86 for common childhood infection. This is a very important chapter for your exam. A lot of questions come from here. So first of all, chickenpox or varicella. So all of you know what is chickenpox. So it is a highly contagious infection caused by varicella zoster virus. And mainly it is spread by, by someone infected, and it is a airborne droplet. So either if you touch the infected fluid from the chickenpox or through the respiratory droplet, like someone coughing, sneezing who has got the infection, they can spread to others. The primary infection with this varicella zoster virus gives chickenpox, and then this virus stays dormant for lifelong in the dorsal root ganglion of everyone who gets chickenpox. So once you get a chickenpox, that virus stays in the dorsal root ganglion, which is like a nerve root, for throughout the life, but it's dormant. Few times this virus can get activated, giving another kind of infection called herpes zoster or shingles. Shingles is not common in children, it's common in adult or elderly patients. So what is the clinical feature of chickenpox? So children will not get any prodromal symptoms. So prodromal symptoms means that before getting the classic chickenpox rash, some patients, especially adult, they can get a bit of like a flu-like illness. So fever, myalgia, headache, and then after 2 to 3 days, they get this classic vesicular rash. So children usually don't get any prodrome. They start with the rash, whereas adults get the prodrome, and then they get this rash, which is a vesicular rash, which has a centripetal distribution. Centripetal means that it starts on the center of the body, so face and trunk, and then it can go a little bit to the extremities. So centripetal distribution is common, and also these are mainly vesicular rash, which means it has fluid inside and it has a cropping phenomenon. So you'll see that in a single patient, there is a lot of rash. So some rash are vesicular, some has papule, some are crusted. So all lesions existing together, which is what we call as cropping phenomenon. So this cropping phenomenon, vesicular rash in a child, that will give you the diagnosis of chickenpox. And it can be very itchy as well. What are the complications of varicella? Most of the time, it doesn't give that much of a complication, but sometimes the skin lesions, the rash the patient has got, it can get secondarily infected with bacteria. Sometimes it can have some scar, and uncommon to get viral pneumonia, eczema herpeticum. Sometimes even they can get acute cerebralitis, where a child who had recent chickenpox can develop ataxia, which means difficulty to keep balance or walk, with a normal mental status. So if they give you a scenario where the child has got a chicken pox, and then after a few days, child having like walking difficulty or having difficulty to keep balance, then you can think of acute cerebralitis. And very rarely it can cause meningoencephalitis. It is not very common for varicella, but it can do it. So that's the rash. As you can see, all of you know how chickenpox looks like, so it should be fine for you. And as I said, it has a centripetal distribution, so you can see it's mainly on the trunk and also on the face. Now, treatment. So there is no specific treatment for it. Main treatment is symptomatic, which means that if there is a fever, then give Panadol. There is no requirement of giving antiviral like acyclovir. Only time we go for antiviral in a chickenpox patient if the patient is immunocompromised, or if the child is like an infant, like a newborn baby has got a chickenpox, or infant, which means less than 12-month old, then you can give them antiviral. Otherwise, there is no requirement of giving antiviral to everyone. And if there is a itching, then you can give some antihistamine. Antibiotic only needed if the lesion is infected. Okay. And it's very important to remember that children who get chickenpox, they can't go to school for 7 days or until all the blisters have dried. Okay. Except for immunocompromised children, contacts should not be excluded from school. So there is index case and contact. So index case means the patient who has got the infection. So for index case, they can't go to school or childcare for at least 7 days or until all the rash has got dried. And there are contact who hasn't got the infection but got contact with the infected person. So for contact, there is no requirement of school exclusion unless that contact is immunocompromised. Okay. So this school exclusion comes in exam a lot in exam. Now this is a chart or table which is super important. And in here, all the infection that we are going to discuss today, you will need to remember what is the exclusion period for the patient and what is the exclusion period for the contact. So you'll need to memorize all of them. Like you can see measles, 5 days, glandular fever, no school exclusion, mumps, 9 days, pertussis, 5 days. So all of these are here. So you'll need to memorize this thing because it comes in exam. Okay. How to prevent chickenpox? Every children in Australia will get a vaccine. So a live attenuated vaccine is suitable for healthy children from the age of 12 months. up to and including 13 years. So ideally, every children usually will get a chickenpox vaccine by the time they are 18 months. Okay, so from 12 to 18 months, everyone usually gets a chickenpox vaccine. So that usually gives them the immunity against it. But for children before 12 months, they are always a high risk to develop chickenpox. Okay, so it is given routinely at 18 months with the immunization schedule. Yes, so from table 86, you only need to know the school exclusion, nothing else. Immunocompromised or newborn antiviral, which day to start? Ideally within 3 days. Okay, so ideally within 3 days of the rash, you should start it. Okay, so that's all about chickenpox. So moving on to measles. So chickenpox, you have got an idea that the classic characteristic for children is that they don't get any prodromal feature, but they get this centripetal rash, which is vesicular in nature and very itchy. Treatment is symptomatic. No specific treatment apart from someone who is immunocompromised can get a acyclovir or any other oral antibiotic. Moving on to measles, also known as rubeola, it is also a highly contagious disease caused by paramyxovirus. So measles has a classic pattern where the children will get 3C. So they get a prodromal feature which starts with cough, coryza, which means runny nose, and conjunctivitis. So 3C followed by a rash. Okay, so it presents an acute febrile exanthematous respiratory illness. So patient who gets measles, they has to have this 3C first, followed by a rash. And sometimes you can also get a elation on their buccal mucosa, which means inside the mouth, opposite to the second molar, which is what we call as coplic spot, which is a tiny white spot, and it looks like a grain of salt. So you can get this coplic spot as well. How to diagnose measles? It's not very common that we get measles in Australia. Very uncommon because of like the immunization schedule. Measles is not very common anymore. So diagnosis is usually clinical, but if you need to confirm it, you can do a measles serology, or you can take a nasopharyngeal swab, or you can take the urine for PCR. So any of these will be able to diagnose measles. So either a blood test for serology or a urine or nasopharyngeal swab for PCR. Okay. So measles, again, it is a respiratory droplet spread. Now, clinical feature has these three stages: prodromal phase, then the rash phase, and then the recovery phase. So prodromal phase lasts for 3 to 4 days, where children gets fever, malaise, anorexia, diarrhea, and the 3C. So 3C you can see in here. So the child having conjunctivitis, having runny nose, and cough. So initially they will have a fever, malaise, anorexia, cough, coryza, conjunctivitis, and maybe a coplic spot. After that, 3 to 4 days after it, they get this rash, which has a typical blotchy, bright red maculopapular pattern. So the rash starts just behind the ears, and then it is spread to the face, and then to the trunk, and then to the limbs. So you can see, so there will be a prodromal feature followed by a red blotchy rash. So it looks like very confluent, not like a tiny spot. Okay. So when you have got this kind of blotchy confluent rash, along with that child has got 3C, then you can diagnose as measles. Okay. And you can see in here that the child had got conjunctivitis, runny nose, and the rash starts behind the ear, followed by the face and then the trunk. So measles can become a serious disease and complications are common. So they can get bacterial superinfection, otitis media, pneumonia, and diarrhea. The commonest complication after measles, as you can see, is ear infection, which is otitis media. Sometimes, apart from this, serious complication can happen, which is encephalitis. They can also get permanent brain damage. They can get this condition called subacute sclerosing panencephalitis, which are not very common, and you don't need to go through this detail. Okay? Just remember that it can happen. No specific treatment because it is a viral infection. So mainly just rest, paracetamol for fever, that's all. You can give you oral vitamin A to reduce the complication, and patient should be excluded for 5 days. And non-immunized contact, which means the contact who are not immunized or vaccinated, they will also be excluded for 14 days from school. So 5 days for the patient and 14 days is school exclusion for non-immunized contact. Every children in Australia, they get MMR, which is measles, mumps, and rubella at the age of 12. And then they get another one at the age of 18 months, where you combine MMR with varicella, which is MMRV. So every children, as part of national immunization schedule, they will get the vaccination for MMR at 12 and MMRV at 18. Okay, so this is how we can prevent measles. Now, sometimes we don't give antiviral for measles, but sometimes you can consider a immunoglobulin for patient who has got measles and they are immunocompromised and under 12 months. So this is one of the other treatment, but just like varicella, like you can give antiviral for infant and immunocompromised, but for measles, if it is immunocompromised or infant and less than 12 months, you can give a immunoglobulin. Okay. Can we use NSAID? It's not needed. So normally we use paracetamol, but if paracetamol itself cannot lower down the temperature, we can use ibuprofen, which is a NSAID. Chickenpox non-immunized school exclusion. Non-immunized school exclusion for chickenpox, as you can see over here. So only those immunodeficient. So 5 days for non-immunized children, okay, and 7 days for immunized. 7 days for the patient, 5 days for non-immunized contact. Okay, moving on to rubella. Rubella is also known as German measles. So it is also a viral infection caused by Toga virus. It is not that bad for children or adults. But if rubella got transmitted from mother to the baby in utero, that's the problem, which gives this congenital rubella syndrome that we discussed last time. How rubella presents? So clinical features of rubella doesn't have any prodromal feature. So no flu-like illness. But the children who develops rubella, they get a generalized maculopapular rash, sometimes can be pruritic. So all over the body, but start on the face and neck, and then it goes to the whole body. Not that common to the extremities like legs and arms. That's not the common, but mainly the upper part, which means face, neck, and the trunk. That's the common part of getting a maculopapular rash. The rash can be itchy, But a very important finding for rubella is a post-auricular lymphadenopathy. So it's very many times that will be the clue in your exam that this child must have got a rubella. So if you get a post-auricular lymphadenopathy with a maculopapular rash with no prodromal feature, that's rubella. So fever is usually absent. Sometimes headache, myalgia, conjunctivitis can be there. Lymphadenopathy is common, which is post-auricular one. And these are the complications which you can go through. There is no specific treatment. It is symptomatic. Most of the time it is very mild. So no need of anything specific. And prevention is by giving the vaccine, right? So MMR at 12 and 18. The child is usually excluded until fully recovered or at least 4 days from onset of the rash. So for rubella, usually 4 days after the rash. That's the school exclusion. So it's not very commonly asked, but just remember if a child has got post-auricular lymphadenopathy and they have got a maculopapular rash, which is limited to the face and trunk, bit of itchy, then you can think of this rubella. Okay, here everyone. So far we have discussed measles, rubella, chickenpox. Now, don't get upset if you think everything is similar, because it takes a lot of time and a lot of reading to get this into your head. So today you can't just memorize all of this when I'm taking the class. So you will need to read it by yourself. You'll need to go through it to understand it fully. All we are doing now is for you to understand the important things from here and get a basic idea. And then you'll need to memorize these things in your own time. Okay. Next, fifth disease or parvovirus B19 infection, also known as erythema infecciosa, important for exam. So parvovirus is commonly known as slapped cheek syndrome. It looks like someone has slapped the child. As you can see, so the cheek will be very red and blushed. That's the main symptom. So it's known as slapped cheek syndrome. It's a childhood exanthem caused by parvovirus B19. Non-specific prodromal symptoms are followed by rash. So initially they get a prodromal feature, and then 2 to 5 days after that, they get this characteristic rash, which starts on the face first, and after that, the whole body will have a maculopapular rash. By the time rash appear, the individual is no longer infective. So that's why parvovirus infection doesn't need any school exclusion, because usually the parents will bring the child when they have got the rash. So by the time rash is there, it is not infected anymore. Okay. So clinical feature, you know that there will be a little bit of prodromal feature followed by a slapped cheek or like a very red cheek, and then a bit of rash. That's parvovirus B19. The problem can happen if a pregnant mother come in contact with a parvovirus infected patient. So in a child or an adult who is non-pregnant, this parvovirus infection is very mild. But if the infection occurs during pregnancy, fetal complications such as miscarriages can occur. It's able to avoid close contact with pregnant women. Pregnant women, so let's say a pregnant mother has got contact history with a parvovirus infected child. So what will you do next? So the first thing you will do is you will check the pregnant woman blood. So you will check her blood for IgM and IgG. So you check for parvovirus IgM and IgG. If only IgG is there, so you know that IgM means recent infection and IgG means past infection. So if only IgG there, which means that the pregnant mother is already immune to it, so you will just reassure everything is fine. If IgM detected, two things can be there. So either it is falsely positive or the mother is infected. Because it can be falsely positive, you need to do a repeat test in 2 weeks' time to check if the IgG titer is rising. If after 2 weeks you see that IgG titer has got elevated, that means that it is most likely an acute infection. Okay. If both IgM and IgG not present, which means it is not acute infection and also the mother is not immune. In such case, you will keep an eye on the mother. If she gets symptom, then you will need to repeat the test again. Okay, so if only IgG positive, that means mother is immune. If IgM positive, then you will need to repeat the test in 2 weeks' time. Okay. The thing is that if, let's say, that IgM positive and you have found that the patient is acutely infected. So if infection occurs in the first half of pregnancy, the fetus can become anemic and it can cause hydrophytalis and miscarriages. So this is the main complication. So the pregnant mother, if they get infection, their baby can become anemic, can develop hydrophytalis. Women in this situation should be reassured that less than 5% women will miscarry and ultrasound monitoring will be done. Parvovirus in pregnancy will not cause any fetal anomalies. If exposure happen in the second half of the pregnancy, you will still do the investigation and you will do everything that you would do for first half of pregnancy infection. So the thing is that at any time of pregnancy, if mother gets in contact with parvovirus and you have found that mother is infected at the moment, there is always a risk for the baby to get anemia hydrophytalis. So you will need to do a frequent ultrasound monitoring for the baby to find out if the child is developing hydrops or not. Okay, so that's mainly the management that you need to do, and it comes in exam. For parvovirus, the treatment is symptomatic, nothing extra that you need to do, and there is no school exclusion for this. Okay. Yeah, so if IgG is rising, it means acute infection. Any questions so far? Are you guys with me? You're understanding everything? Very good. Let's move on. So, roseola infantum. So, roseola infantum is also known as sixth disease. It is a viral infection caused by human herpes virus 6, and it mainly commonly affects the children between 6 to 12 months. So it has a very classic pattern where the children will get a sudden high fever up to 40 degrees Celsius with a bit of runny nose, and then after 3 days the fever will be gone, but a red maculopapular rash will appear. So sudden high fever, after 3 days rash is like fever is gone, but then there is a rash. Rash is confined to the trunk and upper limb, and the child can get a bit of flushed face. So flushed face, and then there is a red maculopapular rash, and then the initial fever that gives the diagnosis that this is most likely roseola infantum or sixth disease. Okay. Again, this is a viral infection. Treatment is symptomatic. Otherwise, there is no school exclusion because child will no longer be infectious by the time symptoms appear. So there is no school exclusion for sixth disease as well. So sudden high fever followed by a rash, that's roseola infantum. The problem with roseola infantum is that the child can get very high fever. And with a 40 degrees Celsius fever, children has possibility of developing a febrile convulsion. So you'll need to make sure that you give Panadol to keep the fever down. Okay. Next, hand, foot, and mouth disease. So it is also very common in Australia, this hand, foot, mouth disease. So this is a vesicular rash caused by Coxsackie-A virus. It mainly happens in children who are in childcare, spread through respiratory secretion. So what happens in this case is that child get an initial fever, headache, bit of a sore throat, and then there will be a rash. It starts as a red spot, then it becomes filled with fluid, which causes this to be a vesicle. The vesicle will then burst and form a shallow ulcer on the hand, foot, and mouth. That's why the name is hand, foot, mouth. So the main symptom is a ulcerative lesion on the palm, sole, and inside the mouth. So if a child has got something like that, then you can diagnose them as hand, foot, and mouth disease. Because it can happen in the mouth and it can be quite painful because the child has got an ulcer. The children has the risk of developing dehydration. So you'll need to assess that during your examination. Children will be infectious until all the blisters have disappeared. Management, symptomatic management is usually the treatment. Now, even though that children will be infectious until the blister have disappeared, school exclusion or child care exclusion is not recommended. So still they say that there is no need for the child to be excluded. So in your, because it's in the JAM and also in RCH, so you'll just follow that. Okay. So the treatment is just symptomatic treatment, making sure child is not getting dehydrated. So enough water and fluid will be the main treatment. Let me show you how it looks like. And there is a RCH guideline also, you can see. You can go through them. So you can see the ulcerative lesion. Sometimes it not be that much worse. Sometimes you can get just a little bit. So you can see a bit of ulcer on the palm and then the sole and then a little bit on the lips. So that's hand, foot, mouth disease. Next, so far all the infection that you have learned is viral infection, but now this is the bacterial infection, scarlet fever. So it is caused by group A Streptococcus pyogenes, and this one, it also starts with a malaise and sore throat with fever, headache, vomiting. So sore throat is a very important finding for scarlet fever. So group A Streptococcus first will affect the throat and it will give a sore throat, bit of a fever, malaise, headache, and then 12 to 24 hours, a rash will appear. First on the neck and then become generalized. It has a classic red boiled lobster or sunburned appearance. So it looks like this. Let me show you. So you can see it looks like a sunburned rash. Okay, and very red in color. So red sunburned appearance rash, which is blanchable, so blanches on pressure, and it's more prominent on the skin folds. So you can see on the axilla, elbow, groin, on the skin fold, it become more prominent. It usually spares the face, palms, and soles. So you can see that around the mouth, there is not much of a rash. So it spares the face, and it also gets this circumoral pallor. So around the mouth or oral cavity, there will be a bit of pallor. So it will not have any kind of rash. And you can also get a strawberry tongue in this patient. So circumoral pallor feels like sandpaper. So the rash will feel like a sandpaper. And don't forget about the strawberry tongue. So to recapitulate, if a child has got sore throat, fever, malaise, and then just one day after that, child has developed a very red um, lobster sunburned apparent rash, more prominent on the skin fold, with a circumoral pallor and also a strawberry tongue, then you would think of scarlet fever. For scarlet fever, you can take a throat swab to confirm the diagnosis that this is a streptococcus infection. Okay. Treatment and antibiotics. So phenoxymethyl penicillin is usually the treatment of choice for 10 days. And children can return to school 24 hours after taking the antibiotic. So once you start the antibiotic, 24 hours after that, child will be able to go back. All right. So that's a scarlet fever. Can hand, foot, mouth disease reoccur? Yes, it can. Moving on to another condition called Kawasaki disease. Kawasaki disease is also important for exam, and there is a RCH guideline for Kawasaki. Please make sure you read that. Okay. So after 24 hours of starting the antibiotic, not completing the treatment. So you start the antibiotic. After 24 hours of starting the antibiotic, child can go. If allergic to penicillin, we can use cefalexin. Okay. Or sometimes we can use azithromycin, erythromycin, those things. So Kefalex will be the next choice. If that is not available, then we can go for any of the macrolides. Kawasaki disease. So Kawasaki disease is not a viral infection, not a bacterial infection. It is a multisystemic vasculitis which can affect almost any kind of blood vessels in the body, but most importantly, it typically affects the coronary arteries. So that's why it is very important to remember. It occurs in children under 5 years of age, but there is a very specific criteria to diagnose this because there is no test which can confirm this diagnosis, but it is a clinical diagnosis. So there is a specific criteria that we need to follow to even consider Kawasaki disease as our diagnosis. So if a child less than 5 years got a sudden onset of fever lasting for 5 days, plus 4 out of the following. One, they get a maculopapular rash, and the rash is polymorphous, which means that various sizes and shapes. So maculopapular rash, you know, that red dot-like rash. Bilateral conjunctivitis, which is non-purulent. Then they can get mucous membrane change, which means dry, red, cracked lips, strawberry tongue, and redness of the oral or pharyngeal mucosa. I will show you some picture, it will become easier. Peripheral changes and cervical lymphadenopathy, which is unilateral, non-purulent, but painful. Let me show you a photo. It will become much easier to know. So this is the main sign and symptoms of Kawasaki disease. So you can see that there is conjunctivitis, but there is no purulence, right? So you say non-purulent conjunctivitis, which is bilateral. You can get a red, dry, cracked lips, strawberry tongue, unilateral painful cervical lymphadenopathy. You can get this kind of maculopapular rash. You can get red, like a redness of the palms and soles. So you can see the sole is very red, and also edema or swelling of the hands and feet. Okay, so that is all your characteristics. So if you get 4 out of these 5 symptoms, so conjunctivitis, cervical lymphadenopathy, red mucosa, okay, and then swelling of the palm, like hands and foot, and a polymorphous maculopapular rash. If you have got 4 out of these 5, then you can diagnose that this might be a case of Kawasaki. Now, to diagnose Kawasaki, this is what we follow. So children with fever for 5 days and 2 compatible clinical criteria. So even there is 2 criteria is there, or infant with fever more than 7 days without any other explanation. So let's say that you have got a child who has fever more than 5 days and even 2 compatible criteria to diagnose Kawasaki. Maybe just a polymorphous rash and then a strawberry tongue. Then you can do a laboratory test to check the inflammatory marker. Okay. If inflammatory marker is high, then you look at if there is 3 or more laboratory finding there, which means child is having anemia, thrombocytosis, which means their platelet count is high, albumin low, ALT elevated, WBC more than 15, or abnormal echocardiogram. If this is there, then the child will need treatment. Now, do we need to memorize all of this? No. So don't even bother to memorize any of this. But I'm giving you an idea that how we manage this kind of children and what are the criteria we follow. But it doesn't come in exam. Okay, so just remember that these are the tests that can be done, but you don't need to memorize any of it. So there is no diagnostic test for Kawasaki, but you can do some laboratory investigation like full blood count, inflammatory marker, liver kidney function. You can do a blood culture. So a lot of things can be done to rule out other possibilities. But it's very important because it affects the coronary artery. You have to do echocardiogram to make sure the child hasn't got coronary artery ectasia, so dilation of the, so they can get a coronary artery aneurysm, and they can even get a coronary artery disease. So to rule out coronary artery aneurysm, you'll have to do a echocardiogram at presentation, then at 2 weeks, and then another at 6 weeks. So this comes in exam. Make sure you remember it. Okay, so every child who you suspect to have Kawasaki will have a echo at presentation, followed by 2 weeks and 6 weeks. Coming back to John Motor, so once you have diagnosed that this could be Kawasaki disease, your treatment, because the major complication is vasculitis, which causes coronary aneurysm and ectasia, which later on can lead to ischemic heart disease and sudden death. Early treatment with immunoglobulin is very important. So for this kind of patient, you will treat them with immunoglobulin, aspirin, and also sometimes IV methylprednisolone. Okay, so the main thing to remember from Kawasaki disease is what are the diagnostic criteria and the treatment. So the treatment for any patient who you suspect Kawasaki, that patient will go to a hospital for further blood test, and they will get an echocardiogram. But most importantly, they will be treated with immunoglobulin as well as IV methylprednisolone. Okay? And remember the follow-up schedule for echocardiogram. Okay, so that's your Kawasaki disease. And also, please read the RCH guideline a little bit. That will be helpful. Mumps doesn't come in exam, so let's move on. Pertussis. Pertussis is very important for exam. It is quite complex. So all of you will need to read RCH guideline for pertussis. Very, very important. Okay. So it is called whooping cough. It's a respiratory infection caused by a bacteria called Bordetella pertussis. Now, this is called whooping cough. The reason is that this kind of cough, it sounds like a whoop. The clinical feature is that the children can get a prolonged cough for weeks and weeks. And sometimes it can become like there is episodes of cough where child cough, 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 and then they vomit. So cough, cough, cough followed by vomit is a classic pattern of thinking that it can be pertussis. So it is highly infectious, spreading to more than 90% of household contact. The classic paroxysmal cough followed by whoop is less common in children. But again, this kind of cough will be really bad. The sound will be very harsh, and in between the cough, children will be completely normal. But when the cough, the child struggle to breathe, and sometimes even they vomit. So if they vomit after cough, that's the time you would think of whooping cough. Okay. So it is also known as 100-day cough because it can be a long time that patient can have the cough. So classic whooping cough is characterized by cough and coryza for 1 week. So initially it will be just a little bit of runny nose, bit of a dry cough. Then the whooping cough pattern will start. So followed by paroxysmal of a more pronounced cough, where the child will start to have vomit. So vomiting may follow a coughing spasm. Okay. So if you get something like that, where a child is coughing for 2 to 3 weeks and then vomiting afterwards, think of pertussis. Diagnosis is clinical, but if you are not sure, then if you want to confirm the diagnosis, then you can do a nasopharyngeal swab or PCR. That will confirm the diagnosis. Okay. And we say that if the cough is less than 21 days, that means less than 3 weeks, then nasopharyngeal swab is ideal. But if the cough is more than 3 weeks, then you will need to go for a pertussis serology to diagnose it. Okay. Complication, it can cause asphyxia, hypoxia, seizure, pneumonia, pneumothorax. Treatment. The treatment usually for children, we can choose between azithromycin, clarithromycin, or erythromycin. So commonly we will use azithro or clarithro in children for pertussis. Okay. All infant under 6 months and older children who got complication will require to be admitted to hospital. So remember one thing, that most of the children who are above 6 months and they're not having these complications, you can treat them as outpatient just with azithromycin oral tablet for 5 days. But if the child is less than 6 months old or having a complications like child developed pneumonia, confused, which suggests encephalopathy, child is getting apnea or cyanosis, that will require admission. Now, because it is a highly contagious disease and almost everyone in the household will contact the disease, treatment of contact is also important. But we don't treat all few things that you need to consider, that everyone in Australia, they get vaccinated against pertussis. So routinely, pertussis vaccine is given at 2, 4, 6 months, and then at 4 year, and then at 12 to 13 year, as per the national immunization schedule. And after this, they get every 10 year, they get a booster. Okay. So if any of the household contact is not having the booster dose in the last 10 years, you will offer that to them. Now, previously, there was a thing that we used to give antibiotic to all the household contact as well. Nowadays, that has been changed. So according to RCH, we will only consider giving the antibiotic to the whole family member if in the family there is a less than 6-month-old infant or if there is a pregnant woman, because these two are the are the people who can get a serious complication if they get pertussis. Again, only time we will treat the contact, which means household contact, with an antibiotic if there is a household member less than 6 months or if there is a pregnant woman at home. Is this is making sense to everyone, guys? And the treatment will be same for those contact, azithromycin or erythromycin or clarithromycin. It is also recommended for every pregnant mother to get a pertussis vaccine in their third trimester, which is in between 20 to 32 weeks. And a booster is required every 10 years. School exclusion, so for the patient, 5 days after starting the antibiotic, and for non-immunized contact, 14 days. Okay, so for the patient, they can go back to school 5 days after starting the antibiotic. So that's pertussis. Again, I say that you need to go through RCH guideline for pertussis because it's very well written there as well. So please make sure you read it. So any question with pertussis management or anything? So for RCH, you will just read the guideline. So it's not memorizing it, just getting an understanding from them because there is a bit of more information in RCH about pertussis. So no, Dr. Amima, treatment is for both patient and the contact. For patient, they will get the treatment with azithromycin, and for contact, they will only get antibiotic if there is a household member less than 6 months or if there is a pregnant woman. And the prevention is everyone in Australia, as part of the immunization schedule, they get the vaccine against pertussis, which is at 2, 4, 6 months. So when they are when they are child, so every child at 2, 4, 6 months, they will get this vaccine. At 4 years, they will get one. At 12 years, they will get one. And then every 10 yearly. And Dr. Manshi, no, there is no specific table where there is all the important information is summarized. You can make one for yourself. There is no school exclusion for Kawasaki. Yeah, so vaccine cannot treat the condition. So vaccine can prevent it. So as I said, that pertussis vaccine should be given to any pregnant patient between 20 to 32 weeks. But if they get contact with a pertussis child, even before that, so even before 20 weeks, they get a contact, then they have a risk of getting the infection, right? So that's why we say that even if there is a pregnant woman at home, then she needs to be treated as well. And that means whole family members needs to be treated. Yes, so basically we have to give antibiotics to patient and the contact. This is only a few infection where we treat contact as well, but not all the time. Only time you will give the antibiotic if there is a less than 6-month-old child at home or if there is a pregnant woman at home. Okay, makes sense, guys? I hope it is. Herpes simplex virus infection. So herpes simplex you know that this is like most of you have got a cold sore. So cold sore is usually the herpes simplex infection. So, but children with cold sore, they can get very unwell because it's a painful ulcer. So they can get refusal to feed because of the ulcer, and they can be prone to dehydration. But the treatment is same. So treatment will be just like symptomatic treatment, making sure the child get enough fluid so that they don't get dehydrated. There is no requirement of antivirals. Impetigo. So impetigo or school sore, this one comes in exam a lot and is very common in Australia. So these are commonly known as school sore. It is a contagious superficial infection of the skin caused by a bacteria known as Streptococcus or Staphylococcus. So impetigo, it looks like this. So you'll need to see the image of it to understand. So school sore can happen anywhere in the body, not just around the mouth, but it's common around the mouth. You can see this honey crust appearance or honeycomb appearance. So if you get this honeycomb appearance on the rash, so you can see that almost every school sore, they have got this honey crusted lesion. So if you get something like that, then you think that this is most likely a impetigo or school sore. Okay. So for school sore, if it is just mild and very small area, and child doesn't have any systemic feature like no fever, no vomiting, then you can just try with a topical antibiotic like Bactroban. But if there is extensive lesion, so multiple areas of the body has got the infection, and then child has got fever, then you'll need to give them oral antibiotic for 10 days. So either flucloxacillin for 10 days or cefalexin for 10 days. The child should be excluded from childcare until antibiotic has been started. So once you start the antibiotic, child will be able to go back to school. Okay? So they don't need to finish the antibiotic. So as long as you start antibiotic, they should be able to go back. Head lice. So you know about the head lice, very common. Only thing it comes in exam is that treatment. So head lice initial treatment is just wet combing, and then sometimes we use some insecticide. So you have got maldicin, permethrin, pyrethrin. So any of these can be tried. If that doesn't help, so you have tried the permethrin, maldicin, the topical one. If it's not helping, then the only way to try it for resistant head lice is cotrimoxazole. So this one came in exam at some point. So if there is a resistant head lice, then you will need to go for cotrimoxazole or Bactrim. Okay. So that's all about childhood infection, guys. There's a lot to remember, a lot of information I know. But again, this is one of the chapter that everyone revise just before their exam because it is really hard to remember. So all of you will remember that this is one of the chapter that you are going to also revise just the night before your exam because a lot of questions can come from here and and it can get quite confusing because most of the symptoms go with each other. Okay. But did you guys get a good idea about it? Any questions? Yes, so you should go through the RCH for hand, foot, mouth disease, pertussis, and Kawasaki. All right, so we're going to take a 10-minute break now. Just try to think what you have learned so far in this 10 minutes, and then we will move on to our next topic today. Thanks. All right, guys, let's start again. So now we are moving on to emergencies in children. So for emergency conditions in children, we're also going to follow GEM because GEM has all the information that we need. And few of these are also on your notes. But I'd like to go through the GEM for this chapter. So chapter 89 is in your GEM 8th edition, which is your emergencies in children. Very important topic for your exam. And few of your question, let's see, for hand, foot, mouth disease, school exclusion, Victoria Health, SA Health, Amedex says until vesicles dry, John Muttag, RCA. So we'll always follow RCH. So RCH has the most updated guideline for pediatrics. Even on the top of GEM, if there is something on RCH, that's what we follow. What to put as password when watching previous video? You have got it, that's good. But with contact, we give acyclovir during first 3 days of rash. For what? Dr. Sharuz, for hand, foot, mouth contact? No, we don't give treatment to the contact for hand, foot, mouths. Does omphalocele cause respiratory failure? Unlikely. Not very common to get a respiratory failure, but as you can see from the picture, it can happen. No, we don't also treat the contacts. So we don't treat contacts for chickenpox, nor we treat the infected patients unless they are immunocompromised or infant. In pertussis in pregnant women, do we give antibiotic only or we give vaccine too? Both. So vaccine for anyone, whatever they are infected or not. So for every pregnant woman, they will get vaccine between 20 to 32. The antibiotic is only if they are a contact of someone who has got pertussis. Okay, moving on to emergencies in children, chapter 89. So this is also a very important topic. So let's move forward. There's a lot to discuss for pediatrics. So first of all, go down. So starting with the solid foreign objects. We had a discussion about solving of foreign objects in our tips and tricks of question solve. So it was one of our trial class where we discussed this topic, high risk foreign bodies, what to do when the foreign body is solid. So please make sure you go through that. So I'm not going to discuss this again. We are moving on to febrile convulsions. So febrile convulsion is important and we go through this from RCH. So what is febrile convulsion? Febrile convulsion is like if a child has got very high fever and because of high fever they are getting seizure or convulsion, that is febrile convulsion. And the commonest cause is just like a upper respiratory tract infection, like a common cold. It's common between 6 months to 5 years and it can recur multiple times. Children who gets febrile convulsion, they have a risk of 2 to 3% of developing epilepsy later on in their life. Okay. Now let's go to RCH to learn about febrile convulsion a little bit. So febrile convulsion, most of the febrile convulsions are benign and it doesn't require any kind of investigation. Management includes identifying the cause of the fever and treat it. So we have We have divided the febrile convulsion into simple febrile convulsion and complex febrile convulsion. So simple febrile convulsion, they get the fever, and with that, the convulsion is generalized tonic-clonic, which means the whole body will have the seizure. It lasts less than 15 minutes and complete recovery within an hour. And it does not recur within the same illness. Whereas complex seizure, it is focal, maybe just one part of the body is having the convulsion. It can last more than 15 minutes and it doesn't get recovery fully within 1 hour. And patient can get multiple seizure in the same febrile illness. There are risk factor of developing epilepsy who gets febrile convulsion. But according to RCH, it says that only 1% risk of having epilepsy after having febrile convulsion, which is not really high. So JM has said 2 to 3%, whereas RCH says 1%. So in exam, if both percentage is there, then you will be sticking to RCH, which is 1%. So for febrile convulsion, there is no need of any investigation. So especially if it is a simple febrile seizure, no investigation is needed. But all you need to do is to find out the source of the fever. That means what's causing the fever and treat it. We don't do electroencephalogram or EEG to diagnose a febrile convulsion. Treatment. So we will treat the seizure or the convulsion. If the child is getting convulsion, then we will treat the seizure as we would do in any kind of seizure, such as, so if a child has got convulsion, then we will put the child in a left lateral position and we can give the child midazolam or diazepam. So midazolam you can give IV, you can give intranasal, buccal, okay, or nasal. So any of these you can do. But if we go for diazepam, it comes either IV or parectal. So you only remember that if a child has got febrile convulsion, first of all, you'll need to find out the cause of it. And if the child is actively seizing, then you will need to give either midazolam or diazepam. Okay. Next, meningitis or encephalitis in a child. So any child, especially if a child has got high fever and there is also a rash, like a purpuric rash, which is not blanchable. So any rash which is not blanchable, that means if you press the rash, it does not fade away or it does not go away. That's a non-blanching rash. So if there is a fever in a child and child looks very unwell, vomiting, bit of drowsy or confused, and then you have also got this kind of non-blanching purpuric rash, your diagnosis should be meningitis, and most importantly, likely chance it is a meningococcal meningitis. Okay, so bacterial meningitis should be considered in an infant who is like having a bit of fever, drowsy, vomiting. So it can present in a lot of way in infant, but if it is a fever with a very unwell and drowsy child, you would consider to rule out meningitis. So if you consider meningitis in a child, what will you do? The first thing is you take a blood for culture and start the child with IV antibiotic. So antibiotic is ceftriaxone or cefotaxime. If it is a bacterial meningitis, then we also give IV dexamethasone. Once the child is a bit stable, then you will do a lumbar puncture to confirm the diagnosis and to know the exact cause of meningitis. But initial treatment is blood culture, start the IV antibiotic and IV dexamethasone. And then when the child is a bit stable, you go for lumbar puncture. Now, meningococcemia. So as I say that if there is a meningococcal meningitis, the treatment is antibiotic. So the treatment is ceftriaxone or cefotaxime. Sometimes this option is not in there. So if If you suspect meningococcal meningitis, your initial antibiotics of choice is ceftriaxone or cefotaxime. That's not in the option. Your other option will be benzyl penicillin. Okay. Now, treatment of meningococcal meningitis is not only for the patient. You also need to treat the contact. Again, meningococcal meningitis has a bit of good discussion in RCH. So make sure you read the RCH guideline for this. So which contact needs to be treated? So we treat the contact who live in the same household and less than 2 years of age, who have kissed the patient in the last 10 days, or have attended the same daycare center. So any of this group will get treatment even if they haven't got the infection. So the treatment for them, if it is an adult or child, the treatment of choice is rifampicin. Only time we would not go for rifampicin is that if the child or the patient cannot tolerate rifampicin or have allergy to rifampicin, then you can try ceftriaxone or ciprofloxacin. For pregnant patient, ciprofloxacin is ideal rather than rifampicin. Okay, so if you not every contact will get the treatment. These are the only contact who is going to get the treatment, and the treatment is with rifampicin for 3 days. Do we need to learn the doses? No, Dr. Hafiz. So we don't need to know the dose, just the name. Yes, so lumbar puncture is only after the child is bit stable. So culture, antibiotic, DEXA, then you go for lumbar puncture. Do we need to study the bacterial viral? Yes, we normally do, but not now. We will discuss that in infectious disease class. Is there any specific time to give midazolam in febrile convulsion? Not really. So you only give it when the child is having the active convulsion. Or sometimes we say that if the child is having generalized seizure, you can't give anything during that time. So at some point the seizure will stop, then you can also give it to them. But if the child is having active seizure and it's not getting over, then you have to go for maybe just go for a IM midazolam. That's the only way you can go for. Sometimes we go for a parectal or buccal. But buccal is not possible when the child is actively seizing. So active seizing either IM or go for parectal. All right. So that's all about your meningitis and febrile convulsion. Moving on to some respiratory emergencies in children. Acute epiglottitis and croup. So acute epiglottitis, it is very, very important for exam. Same like croup, very, very important. So epiglottitis is caused by a bacteria called Haemophilus influenzae. So don't think because it's influenza, it's a viral infection. It is a bacterial. So it's a Haemophilus influenza, which is a life-threatening emergency in a child. And children can become quite unwell with this. So what happens in epiglottitis, that children gets high fever, toxic, unwell, and also they get a sudden onset of noisy breathing such as expiratory stridor. So if a child looks very unwell, high fever, looks very toxic, and having a soft stridor, which is expiratory stridor, then we would consider epiglottitis. Children who develops epiglottitis, they usually don't get a harsh cough like croup, and they don't move their head, so they sit very quiet and they lean forward with drooling of saliva. There is a posture that we say that epiglottitis children can have called tripod posture, where they lean forward and they have a continuous drooling of saliva, and then they don't move their head. Okay, these patients also can also have like swallowing difficulty because The inflamed epiglottis can cause obstruction of the esophagus, causing swallowing difficulty. So basically, if a child looks very unwell, high fever, and having a noisy breathing with expiratory stridor, you would consider epiglottitis as your diagnosis. Okay, so you can see here children with epiglottitis usually sit still with their mouth open, drooling of saliva, and usually lack of movement. Never do a throat examination in a suspected epiglottitis case because you can make it worse. So what is the management? There is nothing you can do to confirm the diagnosis. The only way to confirm is to have a look at the nasopharynx, and if you see a very red inflamed epiglottis, that will confirm the diagnosis. But you would not do it because it can make it worse. Okay, so usually clinical history will give you the diagnosis. So management, the child needs to be intubated because if the epiglottis is inflamed, the air cannot go into the trachea. So child will have severe breathing difficulty. So intubation followed by taking the blood for culture and starting with the IV antibiotic, which is ceftriaxone or ceftriaxone. Okay, so that's epiglottitis treatment. Any question? Now, moving on to croup. So croup is also very important. Croup has a classic pattern where children initially starts to get a like a simple flu-like illness where they come to you with a bit of mild fever, runny nose, and a dry cough. But suddenly after 3 to 4 days, the cough changes its characteristic and it becomes very harsh, barking, brassy cough. And they also have a stridor or noisy breathing, but it is inspiratory stridor. These children doesn't have high fever or doesn't look very toxic like epiglottitis. Okay? So it is caused by a virus, which is para-influenza or RSV. It is common in children, especially after a viral infection. And croup management, so you can't also do any investigation to diagnose this. It is the clinical symptom which will give you the diagnosis. So croup has been divided into mild, moderate, and severe, and the treatment depends on that. So mild croup means child has got very minimal stridor at rest with a bit of chest wall retraction with no respiratory distress. Moderate stridor at rest, but there is a little bit of like respiratory distress, so sternal and chest wall retraction. So mild to moderate treatment is same. So what is severe? Severe means marked respiratory distress causing irritability, pallor, cyanosis, and child looks very exhausted. It is the mental status of the child which will give you the idea that is it a severe croup or mild to moderate. So severe croup means child will become very the child will look very short of breath. So acute respiratory distress, using the neck muscles, the chest wall is going in, and the child looks cyanotic or hypoxia. So if that is there, let's say severe croup. So remember the how loud is this stridor doesn't make is it severe or mild. So stridor will be there for any kind of severity, mild, moderate, or severe. So stridor doesn't give you mild, moderate, severe, but it's the mental status of the child which will give you the idea. So that's where a lot of candidates make it confusing in the exam. They think that if the stridor is very loud, that's severe. It's not the case. Okay. So mild to moderate, you admit the child to hospital and give a single dose of oral steroid, which can be dexamethasone or prednisolone. If that is not available in the option, then you can also give budesonide inhaler, which is also a steroid inhaler. So any of it, dexamethasone IV, prednisolone oral, or budesonide inhaler. And then you keep an eye on the child. So you review the child half an hour after giving the steroid. If after half an hour the child's stridor is gone, then you can send the child home with a second steroid after 24 hours. Again, so you give a single dose of steroid, review the child half an hour later. If after half an hour child is completely stridor free, then the child can be discharged at home. But at home, you can also give them a second dose of steroid after 12 to 24 hours. And you will just ask the parent to give it if still a bit of symptom is there. If after half an hour, still the child having a stridor, then you will treat the child as a severe croup. So severe croup, the treatment is nebulized adrenaline, and that comes in exam. So nebulized adrenaline is 0.1%, 1 in 1,000 concentration. So this 0.1%, this dose comes in exam. So there is very small, there are also there are very limited area where you need to know the dose. One of them is this. So nebulized adrenaline 1%, or we also say 0.5 mil per kilo per dose. So you can repeat the dose of this nebulized adrenaline after 30 minutes if still the stridor there. Okay. With the adrenaline, you can also give some steroids, so either dexamethasone, budesonide, or prednisone. So there's a treatment for severe croup. Any question, guys? Steroid in anywhere, right? So you're giving steroid in mild to moderate also, and also in severe. But for severe, your main treatment is nebulized adrenaline. So mild to moderate, you give the steroid either oral, IV, or inhaler, and then half an hour later, you again check the patient. Check if the stridor is still there. If a stridor is no longer there, then the child can go home with another steroid dose after 12 to 24 hours. Yes, croup can have a expiratory wheezing. So just because a child having wheezing doesn't mean that it is always asthma or bronchiolitis. So croup can have wheezing as well. So wheezing in an infant, what are the causes? Most likely cause of wheezing in an infant less than 12 months is bronchiolitis. Apart from bronchiolitis, any of the others like foreign body, anaphylaxis, heart failure, so any of these can also be the cause. So what is bronchiolitis? So bronchiolitis is, you can say that it's a precursor of asthma. You can't diagnose a wheezing child as asthma until the child is usually 2 years of age. And we say that bronchiolitis is, usually we diagnose bronchiolitis if it is a wheezing child up to 12 to 18 months. So up to 18 months, we can diagnose a child with bronchiolitis. But after that, usually by the time child becomes 2 years, we can diagnose them as asthma if they have wheeze. But bronchiolitis is commonly, it is caused by a viral illness, which is usually due to RSV. It is one of the commonest lower respiratory tract infection in infants. Children usually starts with a bit of runny nose, cough, and mild fever. So initially it is very mild, and then 3 to 5 days afterwards, the symptoms become worse. So child starts to get like more and more short of breath. They get restless, agitated, and they can get very wheezy breathing. So initially a bit of flu-like illness, and then later on the child becomes short of breath, stop eating, and then also getting a bit of short of breath with the wheezing. So that's the time you call it acute bronchiolitis. Remember, all the wheezes is not necessarily an asthma. If you examine or auscultate the chest, you can get expiratory wheeze with inspiratory crepitation. This is one of the way to rule out asthma. So in asthma, you will not get crackles or crepitation, Whereas in bronchiolitis, you will get both wheezing. Okay. Now, investigation. So read bronchiolitis from RCH because they have discussed in a very nice way that you can't do investigations in a simple bronchiolitis chart. So you don't need to do anything to diagnose bronchiolitis. As you can see, X-ray chest should not be used for diagnosis or should not be routinely performed. You don't need to even do a nasopharyngeal swab or PCR to check the virus. So the idea is if it is a bronchiolitis, you just diagnose it as clinically with the sign and symptom, no requirement of doing any investigation. If the child stops eating, having a bit of like vomiting, then only test that you can do is to check their blood sugar level because they can get hypoglycemic. So you can check their blood sugar level. That's the only test, nothing else. Please remember that because it comes in exam and a lot of candidates they choose chest X-ray to diagnose bronchiolitis. It's very clearly written in RCH that there is no requirement of any investigation to diagnose this. Okay? So when it is bronchiolitis, usually admission to hospital is usual, but the treatment is just symptomatic. But if the child oxygen is low, so we say that if oxygen saturation is less than 95, then the child will require oxygen. Okay, so if a child develops bronchiolitis and the oxygen saturation goes below 95, then the child will require oxygen. If child is not eating at all, then you can try NG tube feeding. If NG tube feeding is not working, then IV fluid. There is no need of any other medication, so no antibiotic, no need of nebulized adrenaline, bronchodilator, or steroid. So just because there is a wheezing, you don't need to give bronchodilators. Okay. All good, everyone? Any question? We will discuss asthma later on, so let's not go for it today. Acute heart failure not needed, breath holding attacks. No requirement of cough syrup for cough. Breath holding attacks. So breath holding attack is also important for exam. What happens in this condition is that children who are like between 2 to 3 years, so the toddlers, so during this time, what happens is that let's say that child has got uh, like a emotionally frightening event. So sometimes it could be like child wants to get a toy from the market and you are not giving it to them. And what they will do is that they will start to have a loud cry and then suddenly they can stop or they can hold their breath. If they hold their breath for a good amount of time, they start to become pale and blue because they're not getting enough air. And if it's become severe and they keep on holding their breath, they can even lose their consciousness and they can have a brief tonic-clonic seizure, which does not last more than 60 seconds. Okay, so that is what we call as breath holding attack. Now, this is not epilepsy and there is no risk of getting epilepsy. So all you need to do is to reassure the parent that these are self-limiting and it will get better, not associated with epilepsy or intellectual disability. Then there is aspirated foreign body. So we talked about ingestion of foreign body in our like tips and tricks of question solve class, but there is also a possibility of aspiration. What if the child aspirate a foreign body? So the main symptom, the parents will say that they have seen a coughing or choking episode either while eating a nut or maybe playing with a small toys. And then child will present with persistent coughing and wheezing. If you get a sudden onset of wheezing episode in a toddler with no history of allergy and having a choking episode, consider a possibility of a aspirated foreign body. And most importantly, if you get absence of breath sound on one side of the lung and wheezing wheezing like a unilateral wheezing. So sudden onset of unilateral wheezing in a child with a choking episode and reduction of breath sound on that side of the lung will give you an idea that it is likely to be an aspiration. So what will you do? So you will need to do a chest X-ray to see that if there is anything that you can see the child has aspirated. Okay, so chest X-ray is the main investigation, and the management can be most of the time if the child keeps on coughing, the foreign body can come out. If it's not, then sometimes back slaps, lateral chest compression, Heimlich maneuver, if the child is more than 8 years, can be done. If that doesn't help, and if there is a complete obstruction of airway, then foreign body should be removed with the forceps. If it is not successful, then it can be removed. Like you might need to even perform a tracheostomy or hypothyroidotomy. Okay, so that's usually the treatment for aspiration of foreign body. Anaphylaxis. So anaphylaxis means that we are not going to discuss anaphylaxis in detail today, but just remember that let's say a child has got a bee sting, and suddenly after bee sting, child has developed a severe allergic reaction manifested by like swelling of the lips and tongue, having acute shortness of breath, and child is also having circulatory collapse. So blood pressure is below 90/60, tachycardia. That is what we call as anaphylaxis. If a child having such symptom, then the main treatment is adrenaline, 1 in 1000 concentration, 10 microgram per kilo. And you need to repeat the adrenaline every 5 minutes until improvement. So that's the main treatment, adrenaline. And then you can give oxygen and other things, but the main treatment, remember, is always adrenaline. And that is one thing that comes in exam, and you need to remember the dose of it as well. So that's all that we need to know. The only other thing from the emergency is sudden infant death syndrome. Sudden infant death syndrome is if there is a child who has got a sudden death between 1 to 12 months of age, and then there is no known risk factor, nothing. Suddenly child is dead. That is called sudden infant death syndrome or SIDS. Okay. So sudden infant, there are some risk factors so which you can go through: passive smoking, smothered airway, prone position. So lots of risk factors there. There are some preventive advice which you can read. The only thing that comes in exam is management. So allow the parents to see and hold the baby. Remember that any infant death which is unexplained needs to have a police and coroner involved. So the main thing that comes in exam that you'll need to notify the police and the coroner who will go for a autopsy in this case. So autopsy is must. Okay. So that's all about the emergency cases in children. Any questions so far? And what about it, Dr. Faria? Didn't get your question. Can you explain a little bit more what you're asking? Which one? This is from JM, doctor, the content. So we're discussing from John Murtagh, all of this. All good. So, yes, infection was from John Murtagh too. right? But there is lots of things on the slide as well, but I usually go through the John Murtagh for this case, for these two topics. Now let's discuss a few more for for the respiratory system. So these are already on your slide. So we discussed all of this respiratory condition. So we're moving on to respiratory condition of children. So group discussed, epiglottitis discussed. Sometimes question asks that what is the most common cause of stridor in infant and children? So that is laryngomalacia, which is a congenital like laryngeal anomaly. Okay, so that's only thing that you need to remember. Cystic fibrosis, not very important. We don't discuss that too much. Pneumonia. So pneumonia is a very, very important topic for the exam. So we'll go into discussion about that. We will discuss a little bit of this pneumonia when we do the adult respiratory system. We will discuss a little bit from the JM as well, but mainly at the moment, we will consider the RCH guideline for pneumonia. So pneumonia is a very important topic. Lots of questions come from here. So pneumonia means chest infection, right? And the chest infection can be due to virus, can be due to bacteria, can be due to atypical organism. Community acquired pneumonia, so that means the pneumonia that a child get in the community, many times it can be just due to virus. So if a child is less than 5 years of age, the most common cause of pneumonia is virus. But it's not always that virus is the only thing that can cause pneumonia. But many times after 5 years, the common cause of pneumonia is bacterial infection, and the commonest bug is Streptococcus pneumoniae. Okay. How we diagnose pneumonia? So child will come to you with a fever, cough. Most of the time they will say there is some like yellowish sputum or phlegm. So productive cough, shortness of breath, and sometimes they can have a bit of increased respiratory rate. So if you get a child who has got fever, productive cough, tachypnea, or increased respiratory effort, with that, you can get a classic symptom, classic physical examination finding on auscultation. So when you auscultate their lung, if you get bronchial breathing or a crepitation, that's the time you can think that it is most likely pneumonia. Okay, so fever, cough, shortness of breath. Sometimes they also say a bit of chest pain. And on auscultation, there is crepitation or bronchial breathing. That's pneumonia. Now, if a pneumonia child having dull percussion note and absence of breath sound, that suggests likelihood of a complicated pneumonia by pleural effusion. That is very important. So if it is just pneumonia or consolidation, the breath sound will be bronchial. Okay? And you can get increased vocal resonance or vocal primitus in this child. But if it is a complication, which is a pleural effusion from pneumonia, which is called parapneumonic effusion, in that case, you will get absence of breath sound, not bronchial breath sound, and with that you get a dull percussion note. And for pleural effusion, vocal primitus, vocal resonance will be decreased, which will be increased in just a consolidation or pneumonia patient. Okay, so did you guys understand how to differentiate between these two from the physical exam? Because that gives clue in the exam that what's actually happening in the child. You need to pick up this clue. Now, pneumonia, the treatment or investigation depends on the severity of it. So is it mild to moderate or severe pneumonia? So severe pneumonia should be considered if there is clinical features of pneumonia and one or more of the following. Now that is what you need to memorize. So the child having severe respiratory distress, marked tachycardia, altered mental status, saturation less than 80% or requiring like a respiratory support, or complicated pneumonia such as parapneumonic effusion or empyema. So for severe respiratory distress, you can go for you can have a look of this guideline that what exactly means by severe respiratory distress. Okay, so you can give it a go from here, but remember, depending on the age of the child, respiratory rate can be different. So just go through the Google and find out that what are the normal respiratory rate for every age group in children. So for a 1 year old, there is a respiratory rate which is normal for them. But for a 5 year old, maybe a bit of change. So just get a bit of idea about the normal respiratory rate. Second, marked tachycardia. So if the heart rate is above 120, that's marked tachycardia. Again, for children, according to their ages, the pulse rate is different. So you should know the normal pulse rate for every age group, at least for 1 to 5 years. Altered mental status, we understand what it is. So confused, lethargic child, saturation less than 80, and complicated pneumonia. Any of this is there, that becomes a severe pneumonia. Now, investigations, including chest X-ray, not recommended routinely for a community-acquired pneumonia, especially with mild disease, who can be managed as outpatient. So that's why it is important to know that who are severe. Only time you will be doing all the investigation if you suspect a severe pneumonia. For mild to moderate, there is no need of any investigation. You'll be just treating them with oral antibiotic in outpatient. Okay, so chest X-ray only recommended when severe or complicated pneumonia is suspected, or you are treating a child with oral antibiotic, but child is not improving after 48 to 72 hours. That's the time you will also consider severe pneumonia and get a chest X-ray. Along with chest X-ray, you can also do few other things. So you can do a blood culture for pneumonia patient to know the organism. You can do the full blood count. You can check for some virus and etc. Okay. Treatment. So first of all, does the child require hospitalization? So only the time you will need the hospitalization if the child has got severe pneumonia. So if the child has got severe pneumonia, you admit the child and you start the child with antibiotic, which is ceftriaxone plus flucloxacillin. Okay. And even after starting ceftriaxone flucloxacillin, is still pneumonia not getting better, you can consider IV azithromycin. Okay. But remember the name of these two antibiotics, which is ceftriaxone and fluclox. Now, child is not having severe pneumonia. That means it is mild to moderate pneumonia. For mild to moderate pneumonia, if a child is able to tolerate oral fluid or oral food, then the treatment is oral amoxicillin. But if the child is unable to tolerate oral intake or child keeps on vomiting, then the treatment will be IV benzyl penicillin. Making sense for everyone? No, percussion note will be dull for pneumonia. Now, parapneumonic effusion that also comes in exam. So What is this parapneumonic effusion? So first of all, you will consider parapneumonic effusion, especially if you find all those auscultation finding, or you should also consider parapneumonic effusion if pneumonia has not got better despite 48 hours of appropriate antibiotic. Okay, so if you suspect parapneumonic effusion, you will need to do few things. So first of all, you suspect that it is a severe pneumonia or effusion. First thing you do is a chest X-ray. If it is moderate or large effusion, or if it is a small effusion in an unwell child. So again, if the chest X-ray shows that it is moderate to large effusion and you have already started treatment, like you have given antibiotic orally, it did not work. So what will you do at this point? You will take the blood for culture if it hasn't been done yet, and start the child with IV antibiotic. Because there is moderate to large effusion, you need to quantify how much fluid is there. So to quantify that, you do a chest ultrasound, but after starting the antibiotic. With the chest ultrasound, if it comes as simple effusion, then you just continue the IV antibiotic for 24 to 48 hours. If clinically the child is improving, then you will just continue the antibiotic for total 10 days. If chest ultrasound shows that it is a complicated effusion, such as it's a empyema, that means there is pus in the fluid, or child is having severe respiratory distress because of the fluid, then you are going to send the child or refer the child to a respiratory team for consideration of a intercostal catheter to drain the fluid or a video-assisted thoracoscopic surgery. So basically what you need to do if the child is having severe effusion or child having severe respiratory distress because of that, you'll need to just go for pleural fluid aspiration. But you don't do it, the surgical team or respiratory team will do that. So that's step-by-step management for parapneumonic effusion. Okay. Any question with pneumonia, guys? And Dr. Shira, if patient respond to prophylactic antibiotic given for pneumonia, but sputum culture came with the organism which was not sensitive to the antibiotic, what do we do? You don't do anything. If the symptom is better, then we don't need to give any further antibiotic. It's the symptom that matters. So duration of antibiotic doesn't come in exam, so it's not very important, Dr. Faria. So usually you give the IV antibiotic until the child is stable, and then you change it to oral antibiotic for 10 days. And most common virus for pneumonia, there is no specific thing written in JM or RCH about it, so it could be any of those. So adenovirus, RSV, those are the common ones. Steroid for pneumonia, no need. So no requirement of steroid in a pneumonia child. All right, so that's all for tonight, guys. We will start with the GIT system in our next class, and we'll try to finish the rest of it. Okay? We only change the antibiotic to according to culture and sensitivity if the patient still has got the symptom. But if they're symptomatically they are better with the antibiotic, then no need of changing the antibiotic. Bronchiolitis is usually up to 18 months, and asthma is after 2 years. Okay, so have a good night, guys, and yes, Eid Mubarak to all of you. Thank you. Take care.